All right. So this is kind of a part two, and really it's almost like an ongoing, continuous discussion for us, how our patients mess up treatment. I see it so often where patients want help, but then when it comes to actually doing the things to get the help, they really struggle with that. They really struggle to, what we call the ambivalence, where they want it, but yet they really struggle when it comes to actually implementing it. So this will kind of be just the part two, and hopefully this is an ongoing discussion throughout all of our sessions, is how do we help our patients from sabotaging themselves. So go ahead and hit the next slide. So I just think that cartoon is really funny. And when we talk about our patients, so much of them, there should be a little word there. I don't know if there we go. So reaction versus response. And so many of our patients live in that reaction. They live in that fight, flight, freeze, where they don't think about it. That's all those automatic things that they do. So you might confront them with something and they automatically, and when I say confront, I'm not saying, you did blah, blah, blah. And confronting can be as simple as, hey, I'm concerned about your UA, it was positive. And they may take that as, that's an attack. And so they live in that reaction. So they're always on guard. I like to think of it as being a porcupine. They constantly have their quills out. They constantly are trying to protect themselves from the world. So even when we might be trying to help them, sometimes that is seen as attacking, particularly if our patients have never had a healthy relationship. They may not know what it feels like to actually have someone appropriately address a concerning behavior. So they tend to live in that fight, flight, freeze. And then a response is the action or behavior that involves a mental process. So the response is where you're able to take in whatever the world is giving you, whatever you're hearing, whatever you're seeing, you take it in, you process it, you can then have an appropriate response to whatever it is. So, a good example might be my husband comes home and he's in a cranky mood and he says something, rude or whatever, and I might react with saying, well, blah, 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 and, then the fight is on. Versus a response might be, I take in what he says and I go, okay, well, it's probably not about me. He's probably had a really bad day. It's probably been really stressful and I'm kind of cranky too. So what do I need to say or do in this type of situation? So response is really when we have patients that can learn to respond, that means they're typically utilizing DBT type skills where they're doing some of that emotional regulation as well as that interpersonal relationship and communication. Go ahead and hit the next slide. So there are rational beliefs. There should be a little, there we go. See, I was trying to get creative. Maybe I won't do that anymore. So they have some irrational beliefs that really lead to that getting into that reaction. So making mistakes is terrible is one of those, if you grew up in an addicted or dysfunctional household, that was a rule, don't make mistakes. Because the message then, because those families are typically shame-based, where shame says you are a mistake. Whereas a healthy system says, I've made a mistake, not I am a mistake. So there's the difference between it's who I am versus something that I've done. So their irrational beliefs are making mistakes is terrible. Because if I make a mistake, then I am a mistake. And so therefore, they really struggle with that. And they try to avoid anything that has accountability. So they lie, they manipulate, they push the blame on somebody else, because to actually accept that they have made a mistake is to accept that, oh, now I am a mistake, and no one wants to accept that. So we really have to try to create that environment where it's okay to make a mistake. I don't judge you for making a mistake. I need you to be honest about your mistakes. And so then, of course, they have that belief that people should be condemned for their wrongdoing. So there is no forgiveness. I had a gentleman in my office this morning who was really struggling with, he's made some bad choices. And so feeling like he is just a worthless, I won't use the words he used, but that he's this worthless, horrible person. And at our last session before the session today, I was talking with him and I said, repeat after me. I am a good person. And he couldn't do that. He was like, well, then I'd be lying. And so they truly don't feel like they have any sense of positivity within themselves. And so therefore, if you make a mistake, you are a mistake, and therefore you should be condemned and punished. And unfortunately, for a lot of our patients, if they're in that legal system, they've gotten that message that you've done something wrong and you are now being punished for it. And it's hard sometimes when they're in that legal system to help them understand that it's not that you're being condemned, that you're being held accountable. And we could go on and on about that part. Should be a couple more irrational beliefs. My emotions can't be controlled. So this idea that, you know, in some ways we dance that fine line between, you know, emotions are what they are. You can't control how you feel, but we can control how we express that emotion. And I think that's one of the things that we sometimes get stuck on. I can't control how I feel. If my husband comes home and he does something, whatever, I may feel very angry or upset or rejected or whatever it is. So I'm allowed to have whatever emotion it is, but it's how I convey that emotion, how I express it. That's one of the things we try to teach our patients. And so that kind of goes back to that responding versus reacting. Your emotions tend to be reactionary. You can't necessarily control them, but how we control how we express them. And so that's a big skill for our patients. People must love and approve of me, because again, they can't make a mistake. If they make a mistake, they're wrong. So therefore, if someone loves them or approves of them, then things are okay. So they also tend to have that black and white idea. So, you know, anybody who's been married or in a relationship for a length of time can say, I love my spouse. I don't always like them, but I love them. And so that can be something where if you confront a patient or you point out some flaw or mistake or something that they've done, that it's this idea, well, then you hate me and don't like me. Well, it has nothing to do with that. You know, I can love you or care about you and still find that I don't like your behavior. So really helping them understand that, you know, love and approve, okay, of you, or is it your behavior? And helping them understand too that, you know, just because a person doesn't approve of you doesn't mean that they don't love you or care about you. A lot of our patients, particularly if they are a borderline, they struggle with that idea of not being approved of and accepted. They struggle with, I don't want you to abandon me, so I'm not going to tell you that I've made a mistake. I'm not going to tell you that I did something wrong. I'm not going to be reactive because I don't want to do anything that might make you not like me, and therefore you would reject me. And the next one, threatening situations have to keep me worried. So they always have to be on guard, meaning they're always the porcupine with their quills up. I always have to be preparing for worst case scenario. I always have to be acting as if I'm being threatened, even if I'm not. And so it can be frustrating. I know as a counselor, there's times where I get frustrated when I've got a patient and I have to, you know, reassure them over and over and over again, this is a safe place. I'm not judging you. I'm here to help you. Those types of things, because they don't trust that. They don't yet have an ability to trust and feel safe, and that can be a real challenge for them. And the next, self-discipline is too hard to achieve. And I think sometimes self-discipline gets, you know, even for people who don't have a mental health or a substance use issue, that self-discipline is too hard to achieve. That's hard for a lot of us. You know, if you really think about self-discipline, okay, I'm going to exercise every day, I'm going to eat healthy food, I'm going to do this, I'm going to do that. That's hard for anybody. For our patients, they can get even more rigid about it. So if I even think about wanting a drink, then I'm wrong. Instead of, you know, no, you can think about having a drink, but what do you do with that? Again, you know, I may feel something, but what do I do about it? And so helping them know that self-discipline doesn't necessarily mean you're perfect. Self-discipline means you're continuously trying, continuously progressing to try to make something better. And the next one, bad effects of my childhood still have to control my life. And that is huge, particularly, you know, as we've been going through talking about some of the cases that we've had, you know, when they have this huge ACE score, you know, to think that, okay, your childhood doesn't have to define you is really difficult, because so much of their childhood does define who they are. And so helping patients say, okay, so the crappy things that happened in my childhood don't have to continue to affect my behaviors. I have a patient right now who is absolutely, she is borderline, but she has PTSD. Her parents were physically and emotionally abusive towards her, and she's in her 40s. And so when she'll come in for a session and she'll say, well, my dad called me and he, you know, called me these names and did this and did that. It's like she's 10 years old again. And I continuously have to say to her, okay, but you don't live with your dad anymore. Yes, you have the right to grieve, process, be angry, but when you go drink and tell me it's because your dad called you a nasty name, okay, now there's different ways to go about it, but I often say, well, now you're letting your dad win. because you're letting some stuff that happened 25, 30 years ago affect you today. So it's that fine line between, yes, your childhood does affect you. Our childhood affects all of us, but not giving their power away to it. I find that a lot of patients will use it as an excuse to continue to push their self-destruct button. I had a crappy childhood, therefore I drink, whatever the case may be. And it can be really hard to help them say, you know what, you don't have to be powerless over that anymore. And then the next one, I can't stand the way certain people act. Okay, and again, this goes back to when we talk about self-regulation and reacting versus responding. I may not like the way a lot of people act or what they do. Doesn't mean that I have to take it as a personal threat, and that's what a lot of patients will do. So let's refer back to my patient who her dad might call her and call her a nasty name, and so then she will spend 20 minutes of a session talking about how much she can't stand her dad and the way he treats her. And I say, you know what, you are absolutely allowed to have that feeling. However, what do you want to do with it? We've just spent 20 minutes you talking about how crappy your dad is, instead of deciding what are you going to do from this point forward. So it kind of becomes this self-defeating loop that they get into. And again, it's that idea that, you know, some of our patients like to fall into that victim role of being a victim that, well, if my dad or my boss or whoever didn't act that way, then I wouldn't drink or use drugs or do whatever, instead of it being, well, no, okay, so what's really going on for you? What's underneath it? If that makes sense. And next, people should act the way I think is right. And that goes right along with number 8. Yeah, hey, if Malcolm ruled the world, things would be totally different. But unfortunately, I don't rule the world. So when we talk about patients, again, this is where they try to control the world around them instead of focusing on themselves, which is what they can actually control. So when we have patients that use issues as why they drink drugs, you know, they use it to justify their behavior, instead of saying, okay, you know what, you can't control other people. Really, all you can do is control yourself. You're right, you can't control that you had a crappy childhood. You can't control that your dad is a jerk. You can't control that, but you can control what you choose to do in response to it. And so I'll tell my patients sometimes, the one that I'm referring to, just hang up the phone. When your dad calls you and starts ranting at you, hang up the phone. And she'll say, but I can't do that. And I say, well, why? Hang up the phone. You deserve to be treated differently. And that's really difficult. It sounds simple, but that's incredibly difficult for her to do. Okay, hit the next one. I'm responsible for making everyone else happy. So that's another belief that a lot of our patients, particularly when they come from that dysfunctional childhood background, they believe that they have the power to make everybody else happy. And it's so difficult for them to get away with that. Even people who are, you know, normal, quote unquote, or healthy, quote unquote, feel like I need to make sure that everyone's happy. And it's like, you know what? That is not your job. It is not your job to make everyone happy. That is, you know, your job, again, is only making you happy. And I find so many of our patients try to control the outside stuff instead of the inside stuff. It's a great deterrent. It's a great distraction to control my employer or my spouse or my, you know, whatever. It's easier to control that and focus on that than do the hard work of controlling myself. Okay, next. So again, I like that slide because it's just kind of funny. So what do? We help our patients increase their awareness of what their beliefs are. So, you know, a lot of us have some variation of a defeating belief exercise where they identify their negative beliefs about themselves. They identify that self-talk that's inside their head. They identify those beliefs, and then we try to change them. And it can be really hard because on one hand, we tell patients, well, let's come up with some affirmations. So if you believe that you are a crappy person, every time you think that, I want you to say to yourself, I am a good, valuable person. And that's really hard if they don't really think that, because then they're just lying to themselves. And then that's another mistake. Now I'm a liar too. And so what I tell patients is, okay, so increase your awareness, recognize your self-talk, and it's not enough to simply talk back to that self-talk. You have to engage in behaviors that change that belief. So I have them identify, you know, what would be a healthy belief about yourself? Okay, a healthy belief would be that I am basically a good person. What are the behaviors that reflect that? And I ask them to engage in the behaviors instead of necessarily the self-talk. So engage in the behaviors, because the behaviors will end up changing the belief system, if that makes sense. So identify their errors in thinking. And again, pretty much all of our patients have gone through some type of thinking error group or process where they've identified the errors in thinking. Utilize the deterrent, so utilize the things and kind of like the relapse prevention skills, utilize those things to help you not get into that negative thinking pattern or that that negative belief system. Help do things to get yourself out of that. So, you know, it might be whenever I get into a conversation with my dad, I always end up feeling like I'm a horrible person. Okay, so let's not get into conversations with your dad. Let's focus on, you know, when your dad starts talking like that, that you hang up the phone. Let's have you engage in behaviors that effectively state, I deserve to be treated better. So therefore, I'm going to hang up. I don't deserve to be yelled at like this. And acknowledge the underlying belief and separate the truth from the lie. So I ask patients for evidence of whatever their belief is. And some of our patients, they have a ton of evidence. I've been in prison 3 times. I have lost my children. I have whatever. A lot of them have a lot of truths. And so, all right, we'll identify those and acknowledge those, and then let's figure out what may or may not be true about that. This works great in terms of like eating disorder patients. If they say, you know, well, I am fat, I'll say, okay, I had a patient that I did this with last week. She said, well, I'm fat. And I said, okay, so what is the healthy weight range for someone of your height? And she didn't know what it was. So we went online and we looked at a weight chart. And when she saw that she was 15 pounds under what the minimum weight would be for someone of her height, she was like, oh. So helping them see what is factual and what is not. And so that's a very stark example. For some of our patients, it's harder, but identifying what is the truth and what isn't. And that can be difficult as well. And the next slide. So this is kind of what it looks like. So we want to ask our patients, like, you know, what do I believe about myself or the world around me? And what would this mean about me if it were true or if it weren't true? So this is just a good diagram of the thinking error cycle where you have a thought, I'm not good enough, people will judge me. So it goes into these feelings of being anxious, upset, lonely. They might have a very physical sensation, a tight chest, a headache, tired. Whenever I have a patient that's really talking about some deep emotions, I ask them where they feel it in their body. And sometimes they've kind of almost not disassociated, but disconnected from their body. So they don't recognize that, oh, my stomach pain is because I'm anxious, or my heart palpitation is I'm starting to have an anxiety attack. And so helping them kind of identify, and that goes back to some mindfulness, which is very DBT. I'm going to go back to mindfulness. What am I thinking? What am I feeling? What do I actually need? And then the behavior. And I like to use this type of diagram with patients when it comes to the behavior part to change it. So a patient might get into that situation where my behavior is I drink, I avoid interaction, I eat too much, I avoid things, et cetera, et cetera, et cetera. And I'll say, okay, but do you have to do that? Is that the behavior you have to engage in? And for so many of them, it's become so automatic. That's just what I do. And I'll say, okay, but do you have other options? And then that's a great way to empower them to say, all right, so historically you drink too much, you avoid the interaction, you eat too much, whatever it is. So now what are some other options? You could go on a walk, you could call your sponsor, you could go to a meeting, you could do all these other things. And when I have a patient that's really resistant, I'll say, you know what, you can drink. Go ahead and drink. You know, when you feel like you're crappy, you're not a good person, you're anxious, you're angry, you have that physical sensation, go ahead and drink. But make yourself a promise that you'll do 5 things first. And sometimes they get into that because a lot of our patients are about control. And if we say don't drink, they'll drink just to piss us off. And so when I say you can drink, go ahead, I don't care. But promise yourself, make an agreement with yourself that you'll do 5 things first. And I help them identify 5 things, like maybe it is calling my sponsor, going to a meeting, going on a walk, whatever it may be. Do 5 things. And after doing those 5 things, you still want to drink, go ahead. I'm not necessarily saying go drink, but I'm saying, you know what, if that's the choice you want to make, knowing that you have all these other choices, then okay, that's your choice. But don't give me that excuse that that's just what you do or that's the only option you have. Identify that you have other options. You have different choices, and it's completely within your control to make different choices. And so that's just kind of a nice little diagram that I use. And I think that's the last one. So there we go. That hopefully gives us